Good afternoon and welcome to our first webinar in our series on developing caregiver clinical services. It's a pleasure to have you with us today. I'm Rachel Kennedy. I'm the Strategic Director of Caregiver Support at the American Cancer Society. As you join us, please go ahead and type your name and institution in the chat so that we know who all is here and joining us today. So this is how we'll spend the next hour. After our speakers are introduced, we'll have a brief overview of our Caregivers Clinic Toolkit. If you've had a chance to review that, excellent. If not, we would encourage you to do so, as this series will walk us through the entire toolkit. So it's great to have kind of on the side as you review and go through the program of this series. Next, we'll talk about the need for establishing caregiver clinical services within your cancer center and provide a framework for where to start and share an exemplar program that Dr. Applebaum is leading at Memorial Sloan Kettering Cancer Center. And then I'll tell you about the resources that we've developed at the American Cancer Society to support caregivers, and we'll open it up for questions at the end. I'd love to encourage you to be thinking of questions as we move through the programming today. And please include those in the Q&A, and we'll keep those and organize those so that we'll have great discussion. Please avoid putting them in the chat as it gets kind of messy. So if you have a chance to put those in the Q&A at the end, at the bottom toolbar, you'll see, and we'll be able to organize conversation that way. So now I would like to introduce our speakers. Dr. Allison Applebaum is the Associate Attending Psychologist at the Department of Psychiatry and Behavioral Sciences at Memorial Sloan Kettering Cancer Center. And she's also an Associate Professor of Psychology and Psychiatry at Weill Cornell College. She is the founding director of the Caregivers Clinic at Memorial Sloan Kettering Cancer Center, which is housed in their counseling center. Dr. Applebaum's program of research is focused on the development and dissemination of psychosocial interventions to address the profound mental health needs of family caregivers and to improve their capacity to serve as valuable members of the healthcare team. And Dr. Nick Odom is the Doreen C. Harper Endowed Professor of Nursing in the School of Nursing at the University of Alabama at Birmingham, and the director of the Caregiver and Bereavement Support Services, and in the Center of Palliative and Supportive Care. Dr. Odom is board certified in advanced practice palliative care nursing, and his program of research focuses on developing and testing early palliative care coaching interventions for minority and historically under-resourced family caregivers of individuals with serious illness, particularly those with advanced cancer and heart failure. Both Dr. Allison Applebaum and Nick Odom have the different conflicts to report here in their disclosures for research funding, as you can see. And now I will turn it over to Dr. Odom to get us started.
Thank you so much, Rachel. It's a pleasure to see so many folks join today, where we're going to have a three-part series where we highlight aspects of this hot off the press toolkit that you see there, developing caregiver clinical services. If you have your smartphone and you put it on your camera, at least my iPhone works this way, and you hover over the image there, you'll get a direct link to the toolkit. We do want to highlight that if you have a chance, you'll probably get the most out of these webinars if you have a chance to review the content of the toolkit before coming to these sessions. We're going to hit a bunch of the highlights. And for those who would like a deeper dive, please check the toolkit out or ask questions at the end. So our goal with this series is to provide you all with guidance, tools, resources. The target audience here are clinicians, staff, oncology leaders who want to implement Orifon service line for psychosocial services for family caregivers. This does not need to look the same at each place. It can look different for where you are and leverage whatever personnel and local resources that you have at your disposal. Session 1 will focus on the background of family caregiving, identifying champions to support your program, how to rally support, and how to think about staffing for a program like this. Session 2 will focus on referral, screening, diagnosing, and billing, and that'll be later this month. And finally, Session 3 will be approaches to care and training, marketing, evaluation, and some common pitfalls. That will come to you in early May. So mark your calendars. Okay, so for this session, here are the objectives. Number 1, we want to describe why it's important to support caregivers. I think that we usually don't need to typically convince folks too hard about why this is an important topic and how this might kind of support might be formalized and operationalized through an actual clinical model. 2, we'll discuss ways to identify caregiving champions and secure support from your leadership. 3, we'll reflect on infrastructure considerations, for example, medical records for caregivers or billing considerations when establishing a caregiver's clinic. And finally, we'll summarize recommended staffing models for both startup and maintenance phases of a caregiver's clinic. And as Rachel highlighted at the beginning, we'll also conclude with her highlighting some of the resources provided by the American Cancer Society for family caregivers. So the big questions start, why should we support caregivers of people with cancer? And what clinic model might serve as an exemplar for designing and or refining a caregiver's clinic? And I'm going to hand it off to Allison to help us think about these questions.
Thank you so much, Nick. And it's such an honor to be joining all of you today and seeing so many leaders across the country in caregiving. So I think given who I've seen in the chat, this is not new information. So bear with me. We all know the population of cancer caregivers is growing. Cancer caregivers are defined as family members and friends who provide unpaid care to patients with chronic or life-limiting illnesses. We know, according to the National Alliance for Caregiving, there are at least 53 million caregivers in the US. This is a pre-pandemic estimate. So we can imagine that 2025 data coming out next year is going to show another increase, but at least 5 million of these are providing care to patients with cancer. And this represents a 20% increase since 2015. And these numbers are only going to grow. There are rising healthcare costs, and obviously having a family caregiver can offset this cost. We know there is a push to homebound care, hospital-at-home programs, and shorter hospital stays that depend on the presence of a family caregiver. Of course, there's patient preference for receiving care in the outpatient setting and the cost savings that occurs when patients move out of the hospital. And this is only going to lead to a continued increase in family caregivers in this country. Now, all caregivers, regardless of a patient's illness or disability, experience distress. But we know that the cancer caregiving experience is uniquely challenging. And this report, published in 2016 by the NAC, really highlighted the fact that cancer caregiving is intense and episodic. Cancer caregivers bear witness to suffering on the sidelines and often report feeling powerless. We know that they are tasked with both maintaining hope for a future and also engaging in anticipatory grief as they take care of an individual whose illness is progressing. Very importantly for all of us today, we know that caregivers experience anxiety, depression, and even symptoms of PTSD at higher rates than the patients for whom they provide care. Perhaps the most important thing I say today. And as a result, caregivers are also at risk for their own medical problems, cardiovascular disease, poor immune functioning, fatigue and sleep difficulties, and even higher rates of mortality than the general population. So this is a group at high risk for their own distress and medical issues. And very importantly, if this distress is not addressed while caregivers are in their active caregiving journey, they are then at higher risk for challenges in bereavement. And of course, it's important just to reiterate and pinpoint and say that the distress associated with caregiving does not end with the death of the patient. We know caregivers are increasingly taking responsibilities once held only by healthcare professionals, and this is really strikingly high within the setting of oncology care. And caregivers are unpaid, despite the fact that their efforts were recently estimated at $600 billion. And we know, according to the NAC, up to 1/4 of caregivers experience high financial strain. So there are multifaceted areas of distress experienced by cancer caregivers. Now, we know that when left untreated, distress increases exponentially across this caregiving trajectory. We also know that there are particular points along this trajectory at which caregivers are at unique risk for distress. And I'm guessing that these latter two categories, as patients transition to hospice care and caregivers into bereavement, are no surprise to anyone here. But we want to draw your attention to survivorship. Survivorship is a period when we often see among patients with cancer who are moving into survivorship, reporting having a new lease on life, returning to a new normal, reporting on patient-reported outcomes, lower anxiety, lower depressive symptoms, lower trauma symptoms. Paradoxically, we see the opposite experience in caregivers. And this is likely because survivorship represents the first time that they are able to take an exhale. They're not running around a first, second, and fifth opinions. They're not, being the captain of the medical team. And with that exhale they take comes a rushing in of all the negative emotions they were avoiding during the initial phases of their loved one's diagnosis and treatment. And very importantly, from a health systems perspective, from the perspective of all of us here wanting to support caregivers, this is the same moment when families become disconnected from our healthcare system and yet are very much in need of support. So I want this to be on everyone's radar as you begin to develop your own caregiver clinical services.
So I don't think that I need to really highlight that everything Allison has covered spotlights this one statement, which is that caregiving support, both in their role in supporting the patient and delivering high quality care, and because their own health is at risk in this role, is more critical now more than ever. So let's do a poll. Does your cancer center provide caregiver support? This can include anything from information and resources to support groups or counseling services. Let's see where everybody is at. We'll take about 30 seconds. All right, I'm guessing most folks had a chance to respond. Let's see. Okay, so 85% of folks on the call do provide some form of support to family caregivers. That is great to see. 10% do not, and 6% are unsure. And so that should give everyone a sense of where we stand with providing caregiver support, albeit I will highlight that based on some work that I've done and Allison as well, that the type of support can vary substantially, not only between cancer centers, but even within cancer centers, given that they can often be large. It's often difficult to know if there are services available for one cancer type or stage and not others. And so that some folks are endorsing they're unsure, I think in part speaks to the fact that one can become a little siloed within their own cancer center, and it's often unclear what resources are available even within your own center, much less across centers across the country. So thank you everyone for that. So you want to start a program, you need to make a case, you need to have some advocates on your side. What are some benefits of supporting cancer caregivers? First, as Allison highlighted quite well in the prior slides, higher distress in caregivers has been linked to inferior quality of care and patient care outcomes. Numerous studies have found that the better that we can take care of caregivers, that the more patient outcomes appear to improve. Second, poor caregiver well-being has been associated with higher Medicare expenditures, ER visits, and unnecessary and aggressive care at the end of life. Third, receipt of psychosocial support and education by caregivers has been associated with lower hospital readmission rates and lower overall healthcare costs. These are all important considerations when you're wanting to make a business case for these caregivers. I think a lot of us are very much compelled by the simple fact that it's the right thing to do. That also needs to Venn diagram overlap with it being a feasible, realistic model that can be actually delivered within a sustainable business model over a period of time. Finally, support delivered early in the caregiving trajectory can prevent many poor psychosocial medical outcomes for family caregivers. And so in many ways, one might think of this as a cost avoidant strategy, such that when you deliver support early on to caregivers, when they still have bandwidth, when the patient might be sick, but not so sick that they can't receive, the circumstance and context are not so stressful that one can't learn new things or new skills, that support delivered early on has an inoculation effect for problems that may come up down the line. So with that, Allison is going to provide one of the national leading exemplars of a caregiving program, one of the first in this country. And so Allison, take it away.
Thank you, Nick. So I want to tell you a little bit about the beginnings of the Caregivers Clinic at MSK. I started at MSK as a postdoctoral fellow in 2010. I was primarily providing care to patients with advanced life-limiting cancers. And what was so striking initially to me was how prominent the role of family caregivers was in these patients' lives. I also realized that caregivers within my own institution did not have available resources targeted to their own unique needs, and that this was mirrored in cancer centers across the country. And yet we already knew, documented in the literature, that the distress experienced by family caregivers was profound. And so in 2011, I founded the Caregivers Clinic at MSK, whose mission is to assure that no caregiver experiencing significant distress as a result of their critical role goes unidentified and deprived of necessary psychosocial services. The clinic provides caregivers provides care to caregivers of patients with all sites and stages of cancer across the entire caregiving trajectory, from diagnosis through bereavement. I wanted to share some data with you. These are a little bit outdated now. These are from 2021. This was our 10-year data. At that point, we had provided psychodiagnostic visits with 408 caregivers who went on to receive over 4,000 psychotherapy sessions. We conducted 3 group therapies, had 3 ongoing groups. 98 of these caregivers went on to receive either couples or family therapy sessions ad hoc, meaning this was not a purposeful ongoing family or couples therapy, but sessions conducted ad hoc to address a targeted issue. For example, helping a couple to engage in advanced care planning discussions. And additionally, 244 of these caregivers either requested or required medication management. And I should say that this data was put together in 2021, 1 year into the pandemic, and our referrals increased exponentially. So I would not be surprised if we've at this point conducted closer to 1,000 psychodiagnostic visits. Next slide. So how do we begin? How do we identify caregiver champions and secure leadership support? This was the first step that I took and is likely going to be the first step that you're going to take. And we're going to go through these 10 steps, which are explored in detail in the toolkit, but we want to highlight for you right now to really get buy-in from leadership, because we cannot build these programs as an island of 1 or 2 or 3. We need to do so with the support of our institutional leadership. So starting with number 1, we need to actually understand what is both the formal and informal leadership structure. How is it organized? Who's really in charge? Who's actually making the decisions? How are decisions made about clinical processes? Who are the key players? It's not always obvious, especially if you're not someone already in leadership, right? So that's a lot of info gathering. Number 2, it's going to be critical that you find a champion who is committed to caregiver support, somebody who's passionate, persistent, and politically savvy. Now, back when I began the Caregivers Clinic, the champion I identified was Dr. William Breitbart, a psychiatrist and chairman of our department. I identified him, number 1, because he was passionate, persistent, and politically savvy, and a champion for caregivers. But number 2, he had influence way higher up than I could have ever had. And he was able to be a voice within let me just label an elephant in the room, an MD-focused institution where I'm a PhD psychologist. He was able to be an advocate for establishing this type of support. It's critical that you find a champion, at least 1, more than 1 is even better. Third, It's going to be important that you research and develop examples that demonstrate how supporting caregivers can improve patient outcomes and satisfaction, because key words, patient outcomes and satisfaction. That is what leadership wants to hear about. And so if you can start right off the bat with exemplars of this, that's going to help your case.
Number 4, once you've understood the leadership landscape, you've identified champions, you're starting to meet, you've started to build a compelling case. The next thing to think about is tailoring a message. You want to craft a message about this new service that resonates with the specific interests and priorities of specific leaders at your institution. You want to emphasize how the Family Caregiver Support Service aligns with your cancer center's mission, strategic goals, and values. If you've never looked at your cancer center strategic plan, now's the time at this stage. You want to align your language and the purpose and outcomes of your center with those goals so that it's perfectly aligned with the larger cancer center's mission. Number 5, you want to engage early and communicate effectively with the leaders and keep them updated. If you initiate early communication with leaders, you develop a relationship with them by providing them updates, progress reports. What you do is you're maintaining their energy level and engagement and their level of involvement. You can do this by clearly articulating the purpose, goals, and expected outcomes of these new psychosocial services, and be able to, at some regular interval, delivering them objectives met, or sort of deliverables or tangible objectives that have been met over time, to keep them involved, keep them engaged. Number 6, you want to collaborate and actually involve these leaders. You need them to also co-own this clinic with you by having them involved in both the planning and decision-making processes, seeking their input, incorporating their suggestions. It fosters a sense of ownership for them, so they also feels like this is their baby too. In a sense also of shared responsibility. Demonstrating that their involvement is essential helps you have successful implementation over the long haul and helps you sustain the program and their engagement long term.
Number 7, addressing concerns and mitigating risks. So it's going to be very important that you are ready right off the bat to address concerns and potential risks, about potential risks. So for example, the number 1 concern brought up to me in the beginning was, you are going to open the floodgates. What is going to happen and how are you going to handle it, right? And so it was very important for me to start to address that early on and to develop a plan that would actually address the issues as they potentially could unfold in the future. And number 8, be ready to share success stories from other cancer centers that implemented caregiver support services. Now, I didn't have this opportunity when I developed the clinic. It would have been so much easier for me if I had that. So I encourage you to use the clinic we have at MSK and any other exemplars across the country as the model, to be able to say to your leadership, look, we're not going to reinvent the wheel. This has already been done. It's been done successfully. There's a model that is self-sustaining and even revenue generating. Key phrase they love to hear, right? But to be able to point to another institution and say they've already done this and we want to implement the same structure is going to absolutely facilitate the process.
Number 9, establish accountability and evaluation measures. So I'm a researcher, I love numbers. And when you're thinking about setting up this program, it's important to make sure that you have tangible, objective evaluation measures and metrics. They don't need to be large. You don't need to see 100 people in 6 months, but just having goals that you set and having clearly defined roles and responsibilities of all the people involved in starting and sustaining this clinic, including the leadership support, will help you have input about what these evaluation measures need to be and how to measure them. You want to have mechanisms in place to monitor and evaluate the effectiveness of services, including regular reporting on key metrics, feedback from caregivers and staff, and anything you can do to have sort of a continuous QI or quality improvement initiatives in place so that you're constantly reporting data to your key constituents, particularly leadership who's hopefully helping you in part to fund and financially sustain the program. Finally, number 10 is to also highlight palliative and supportive care services. One way that you can offer a carrot to your cancer center is that having such a center for caregivers actually meets a Commission on Cancer quality standard, specifically 4.5, for offering palliative care services, which states, quote, that palliative care services are available to cancer patients and their family members or caregivers. So having a clinic like this would help you meet that COC accreditation standard. The availability of such of these palliative care services is also an essential component of cancer care to begin with, beginning at the time of diagnosis and being continuously available throughout treatment and surveillance, and when applicable during bereavement. So again, this is another way that you can frame and contextualize your service to be an added benefit to the cancer center, and then being able to meet accreditation standards. So what are some things that you all might want to think about when creating the infrastructure, the tangible things to support a caregiver's clinic?
When I began the clinic in 2011, I think one of the most important steps that I took was advocating that caregivers would register to become patients of Memorial Sloan Kettering Cancer Center with their own medical record and own medical record number. I realized that historically, caregivers have been seen on occasion by psychologists or psychiatrists in the department, but their data were documented in the records of patients. Their information about their psychotherapy session was put in the record of the patient, which of course presents many challenges. Having a separate medical record for caregivers allows for identification of caregivers and of course their documentation of data. Most importantly, I think, is the fact that we can then preserve privacy and confidentiality. Next. So of course, having a separate medical record for a family caregiver and medical record number means that their specific data is housed separate from the patient. And I will just say, for many caregivers who've come to see us in our clinic, knowing that has been really instrumental in their engagement in care. If they were under the assumption that their data would be housed in the same record as the patient, my guess is they might have been less forthcoming in those sessions with our providers. Perhaps most importantly to our leadership, of course, is the benefit of a medical record in terms of billing. When you have a separate medical record for family caregivers, you then can separately bill that caregiver for the services and therefore generate revenue, which of course is one of the benefits to the institution of having these programs. And very importantly, often when patients die, their records are closed or access is very limited. But when you have a separate medical record for family caregivers, it facilitates continuity of care into bereavement. Moreover, and I wrote about this in the toolkit and elsewhere, one of the major challenges caregivers face right now is time off from work in bereavement. Our current public policy landscape does a terrible job of this. Oftentimes, caregivers get just 3 days off, that's it. And for somebody who's been a caregiver, as I was to my dad for over a decade, to be told you only get 3 days is not okay. However, if you have a medical record in place documenting caregiver distress and engagement in psychosocial care, those data can be used to support a disability claim that can allow that caregiver to be out from work, fully paid for a certain period of time to engage in mental health care. So there's some other very significant benefits to having these records for caregivers. So, another poll question. Are there any caregiver data documented in patient records at your cancer center? Curious to see the results here. All right, great. Okay, so 25% said yes, caregiver data are documented in patient records. 46% no, and 29% unsure. And that's not surprising to me whatsoever. I'm going to tuck these data back into my mind for a second as we move on. Thank you for completing that poll. So many of you all might be familiar with the Caregiver Advised Reporting Enable Act, the CARE Act. currently passed in 45 states and territories. So the CARE Act has 3 provisions. The first is that hospital systems should be documenting caregivers' contact information in the record of the patient. And my guess is many of you who said yes to that poll, the yes may have been a response to yes, caregivers' contact information is put in the patient record via CARE Act regulation. The CARE Act says that we need to be letting caregivers know when patients are going to be transferred or discharged. And I think very importantly, it says that we as hospital systems are required to provide instruction so that caregivers know how to take care of their care partners upon discharge. Now, we can agree, probably, I'll just say it out loud, that the CARE Act is not consistently implemented as of now, but I would also say that this third point here is a beautiful opportunity for the creation of a caregiver record to not only be documenting caregiver contact information in a patient record, but perhaps even taking it a step further and screening caregivers for distress at that moment at hospital discharge and having a record generated in which that data can go. And then if that distress screening indicates a need for a higher level of psychosocial care, then the record's already in place. And that caregiver can be seen by a professional within the institution. We'll be talking more about that.
So some quick tips. So I direct what's called the Caregiver Bereavement Support Service. It's called a service, but it's a bit of a misnomer. We provide guidance and implementation expertise to existing departments and service lines to implement caregiving support. And there's often a conversation about what do we need to know about documenting work that we do with caregivers. So here's some quick tips that I often share with folks. Number one, ensure that you have approval. You want to meet with your representatives from your institution's informatics department, number one, to see if there's any unique steps you need to take to create a caregiver record. Similarly, I would highly recommend involving a representative from your legal department to ensure their approval. If your legal department is one which is a little, I don't know, how do I say, highly compliant, you can give them examples such as Allison's service at MSK or other institutions that have similar sorts of services, so they at least have some precedent to work from when they're trying to assess legal risk. Number two, emphasize the benefits to leadership if there's pushback. Highlight protections to confidentiality and privacy. There is an open notes law at the moment, and so patients are entitled to see the very notes that we chart in documents. And so this might make some leaders a little skittish. And so strategizing such that you are able to offer some protections to confidentiality if you're going to be documenting information about caregivers that you wouldn't necessarily want to have the other party seeing and to ensure privacy. Three, the structure of the record. Caregiver records, I mean, they can be identical to those of patients that you're seeing in oncology. To differentiate, we'd suggest opening at minimum the HPI section with some version of, Mr. or Mrs. Smith is the, whatever their role is, partner, parent, child, and primary caregiver of patient, insert name and MRN number, being treated at this institution for blank. The benefit of having the patient's MRN number here, and again, you want to make sure this is good with your legal department, is that you're able to link records and demonstrate at some point in time that services and support being delivered to caregivers impact patient outcomes. And you could, in theory, look at patient outcomes by seeing their name and MRN number linked here in the record in this way. So just a suggestion. Number four, capture key caregiving related data. There are reports out there that detail what might be ideally captured in an HPI section of a caregiver focused record. We would say that you would want to at least highlight their amount of time they have been a caregiver and how many hours per week they're providing care, what the prior caregiving experiences are, and any pertinent experiences of loss that this individual is or has experienced in the past. Okay, so what kind of staffing model is recommended when starting and sustaining caregivers clinic?
So when I began the Caregivers Clinic, I was the clinic. I want to label the elephant in the room. Okay. So these clinical services can begin with just one individual, though ideally in a perfect world, it does not stay that one individual for too long. So here and in the toolkit, we go into greater depth in this. We have 2 staffing models for you, and we can come up with 5 more iterations of this. But I would say to start off, what's going to be important is to have a clinical psychologist or another mental health professional who has the capacity to bill for services. Now, in my current institution, social workers are not allowed to bill for services, but I do know of cancer centers where that's not the case. And so perhaps in another cancer center, that half-time provider might be a social worker. But the idea is that because the billing aspect is one of the important elements here, of course, for leadership and buy-in, you will want to have somebody available who can bill for services. And so a half-time effort would be at least 2.5 days a week to provide clinical care to start. You also want to have the availability of somebody who can provide medication management, a psychiatrist, a psychiatric nurse practitioner, someone who can prescribe psychiatric medications if necessary. And so we recommend somebody who could potentially devote a quarter of their effort to the clinic. Perhaps it's just identifying an advanced practice provider, a psychiatric nurse practitioner, who will be available in the case that a caregiver needs additional support. So it's important to have that person identified with the potential to give up to 1/4 of their time. And then you need a clinic administrator, at least a quarter of their time. Now, if you are embedded within a larger counseling program, as our Caregivers Clinic was, that was you relying on one of the clinical administrators already in place to give a certain proportion of her effort to the scheduling and referral and coordination and the administrative tasks for the clinic, though eventually building up in that ideal staffing model, somebody who can devote at least half time. Now, let me be transparent. An ideal staffing model is 5 full-time clinicians, but we all know in this room that is not going to happen immediately. So we're going to define an ideal staffing model as 1 full-time clinician who can provide at least 80% clinical care. That is 4 full days of clinical time. And then that 5th day used to provide training and clinical supervision, as well as administration. Now, one thing we do go into the toolkit in depth is, and we'll go into one of in the future webinars, is the opportunity for training pre and postdoctoral fellows, clinical psychology externs and interns, social work students, nurse practitioner students to receive clinical training in the clinic, who then can provide additional clinical care to caregivers to really buoy up the resources you have. But I would say ideally you have 1 full-time clinician to provide psychotherapy and those psychodiagnostic visits, and up to a half-time prescriber, psychiatrist, psychiatric nurse practitioner, and then, of course, at least half-time of a clinic administrator, because those floodgates will open, and you will need somebody who's going to assist with the screening and the scheduling and referral of caregivers to your variety of providers. So these are 2 staffing models. Again, the drive-home message is to start. Do you have 1 person who can bill, who can provide psychodiagnostic visits and psychotherapy to caregivers in need? And I'll turn it over now to Rachel, who's going to speak about the amazing support for family caregivers through the ACS.
Thank you so much, Allison. Nick. I really appreciate it. So we'll shift gears now into kind of how we've been developing resources that you can share with your caregivers that you serve at your cancer centers. In 2015, the American Cancer Society established the very first ever caregiver support program, with the goal being to develop and implement innovative and evidence-informed resources to measurably improve the lives of caregivers. And as you can see in this graphic here, it represents really some of the most prevalent issues that you've heard about today, some of those things that are the major things that impact overall quality of life. And knowing how overwhelmed caregivers are and all of the things that they have to balance, those plates, balancing and spinning. So our resources were created specifically to meet their needs across the cancer trajectory. So all of the resources that I present on today are available in English and Spanish, and the short links are there. We will also be providing a little bit later in a couple of slides, 1-pagers for you to download and print for your cancer centers, or even just email out and distribute that way. So the first resource is our caregiver resource guide, and it's a comprehensive compendium of information aimed at increasing caregiver preparedness and helping them feel supported and less overwhelmed around all of the expectations of providing care. So it's made up specifically of 8 sections. And there we go. So the cancer caregiving section really is, what does it mean to be a caregiver? What are the expectations of that role? Caregiver self-care is, how do I take care of myself while I'm providing care, right? So some tips on some healthy eating, and also our screening guidelines around nutrition, physical activity. Then we have a section on communication, specifically when the patient and caregiver dyad, but also how the caregiver can make the most out of the time with the cancer care team when you have all of those questions to ask and a lot of information to gather, and really organizing those conversations. The cancer information section really hits the basics. It starts with, what is cancer? A lot of people don't really even know what it is. So that what is cancer? How does it develop? Some of the common myths that are surrounding cancer diagnosis, and then how people may change both physically and mentally as a result of having it. And then we have cancer treatment. So within that section, we hit on surgery, radiation, and chemo, and then the side effects from those treatments. And then also provide some resources around what if treatment stops working, and how can I help my loved one cope with that. Patient nutrition is a huge, huge element of caregiving. So here we describe how eating the right kinds of foods before, during, and after treatment can really help the patient feel better and also keep them strong. Coping, again, this huge element of the psychosocial support and mental health issues around anxiety, depression, anger, resentment. So offering tips around how the caregiver can help and support their loved one, but then how can they also manage their own distress? We end the guide with caregiver resources that we provide, and then also others that are provided outside of ACS. Again, available in English and Spanish. And we're just absolutely thrilled to have this as a dual language resource. So some of the themes that were in the guide carried over into the development of a caregiver support video series. And we've really chapterized these videos into kind of the bulk of caregiver self-care. So you can see some of the elements that were kind of carried over from the guide. The physical care training piece is really where the majority of the videos live. And this is that extension from the cancer center and that medical care from the hospital setting over to home. So you get a lot of that anxiety of like, oh no, I am not trained to do this. How do I drain a Jackson Pratt drain? So we have a video specifically on that. And it's quite viral in both the English and Spanish series. So you might want to check it out. And then we have, of course, those side effect and pain management issues around, how do I help my loved one when they're just nausea, vomiting, mouth sores, et cetera. So again, that physical care training videos are really where caregivers experience a lot of anxiety leaving the clinical setting and then coming home and not knowing and feeling prepared. And then we have a video again on communication with the cancer care team and how to really organize those conversations so you feel like they're most efficient. Personalizing the caregiver experience through stories. They're very, very touching. You should check them out. It really, really humanizes kind of the entire experience and gives me even more, motivation and purpose for what we do here at ACS. Again, the series is available in English and Spanish, and the QR code will take you there. So our newest program has launched this past year. It's called ACS Cares, and it was designed to provide this non-clinical navigation support to both patients and caregivers. So the model here is really, it provides kind of that digital strategy of virtual support as well as in-person support. And it's made up of 3 components. We have a digital app, which is that ACS Cares. Again, you can find it where you get your apps. And it utilizes the ACS social determinants of health assessment to really kind of personalize information around the cancer diagnosis, treatment, and experience. And so you're then left with kind of this curated information specifically for you. And then we also have an opportunity within the app to contact our National Cancer Information Center, which is staffed by humans 24/7, 365 days a year. And so you have that personal connection with somebody who can then connect you and navigate you to the right resources. And then there's the personalized support from trained volunteers. So we have volunteers that we have trained on the entire curriculum and the entire program around, how do we match you with resources depending on where you are across the trajectory? And then we also have in-person support from some of those volunteers in cancer centers. This year, I'm currently working to expand the caregiver pathway of the app. Nearly 40% of the registered users are caregivers. So we know that there's a huge need there, right? So we're expanding that pathway so that caregivers get more specific information and resources and that they're navigated to them appropriately. And then lastly, I do want to share about our Hope Lodge program. For those of you who aren't familiar, it's a free place to stay, right? For patients and caregivers who have to travel to treatment. And this is really a home away from home environment for folks. And it really humanizes and gives a heartbeat to the American Cancer Society mission, right? So you have an opportunity to stay there completely free of charge. You're never asked for a dime, and you have patients who a lot of time, this is a huge barrier to care, right? When they can't access anywhere to stay. So this, if you're not familiar with it, again, check it out at cancer.org/Hope Lodge. You can see the impact here. We have 31 lodges across the United States. And in 2022 alone, you can see how impactful it was in both the volume of patients and caregivers we served, and also in the lodging costs that were saved for folks who stayed with us. So we have reached the time to interact with you guys through questions. I see some questions populating in my Q&A box, which I absolutely love. I'm so excited about that. But there's more to come. If you haven't registered for our second webinar, it's happening again later this month. It's on that referral screening and diagnosing and billing, which is a critical piece of this reimbursable model. And then in May, we'll end this series with approaches to care training and really how to promote and disseminate and let folks know that this program exists in your cancer center. And so also you can reach out to any of us via email or any on social. You can also find us on LinkedIn if you want to connect with us professionally there. So I will open it up to questions. Let's see here. And thank you, Reagan Varnado. I saw your question come in earlier. So she says, I work at a cancer center that does not charge or bill for social work, counseling, or nurse navigation. What do you suggest, or what insight do you have about implementing something like this model when you are not technically any financial benefits to the hospital/cancer center? Great question.
Yeah, this is such a great question. I'll take it. So, something I often say is that, yes, we bill for services, but the revenue that I generate will never match that of my medical oncology colleagues, right? So I'm not bringing in the exact, the magnitude that they are. So it's always been important for me to also mention all of the other benefits that come from providing caregivers with support, including the fact that a well-supported, trained, educated caregiver is likely going to be better able to provide care for a patient at home, better likely to be able to identify signs and symptoms of an adverse event early, prevent hospitalization or unnecessary admissions, and basically lead to improved quality of life. And there is a large and growing body of literature demonstrating these outcomes. And I think those are some that you really want to highlight, that cancer care, the success of cancer care, in so many ways depends on that caregiver who feels supported, educated, trained. That can make a significant difference. And so maybe you're not generating revenue, but there are many other compelling arguments that you can present.
Thank you. And Dr. Odom, I will ask, what recommendation would you offer to an institution that currently does not provide any caregiver programs? Where do they begin in designing programs for caregivers?
Yeah, I would say that you don't want to start too big. You need to start with something that's realistic, and you need to start identifying who's on your team. I would start there. Start looking around for other people, look for a leadership champion, understand the strategic plan of the cancer center and what they're doing, just meet with people and start there. Really just small steps to start if you really don't have anything. You know, get a sort of an environmental scan of what resources you have at your center in terms of personnel and resources, and make sure that you understand all that, and just start meeting with people. And once you start finding people who have the same energy for this as you can start strategizing, what could we offer with this team, with these resources? And again, I would strongly caution to start small and be very realistic when you start to get going. That's all.
Excellent, excellent. And then also, are caregivers without insurance able to access services at the clinic?
So this is a really important question. So we just, I spoke about the importance of having somebody staffing the clinic who can bill for services. But of course, there are caregivers who are not going to have insurance coverage for mental health care. So what we've done in the clinic at Memorial Sloan Kettering Cancer Center is routed those caregivers who don't have insurance coverage to be seen by one of our trainees. Now, trainees are not able to bill for services, pre and postdoctoral fellows, clinical psychology interns and externs. They are supervised by myself or another licensed professional who does bill, but they themselves cannot actually bill for services. So the model is usually that the first diagnostic visit must be a shared visit between a trainee and the supervisor, myself. In these cases, we have been able to have that fee waived for that one visit for those caregivers who are unable to use insurance. And that was an agreement made through patient financial services on a case-by-case basis. But all subsequent visits conducted by a trainee are free of charge. And so that's one of the reasons why I didn't put in the ideal staffing model explicitly, but ideally, you also have trainees who are going to be able to see caregivers free of charge. Similarly, if your center has social workers who don't bill for services, those social workers who are not trainees should be assigned to those caregivers who don't have insurance.
Very good. Okay. And kind of an extension of that, is it possible to establish a caregiver's clinic independently from the parent institution where the cancer center is located?
So if this is a question about where the caregivers clinic can exist, I want to be very clear that the Department of Psychiatry at MSK has always been separate from the main hospital. In fact, we've been historically housed on a random floor in a business building. That's where psychiatry has been housed. So we've always been separate. I'll also be honest and say that since the pandemic, our care has been 100% virtual. So my answer is absolutely. You can be separate and you can potentially be doing it from home, which is the model that we have right now at MSK. You don't need to necessarily be co-located with the cancer center.
I would just say in addition to that, that if you, depending on what one means by independent, one scope of practice is in part covered by the fact that when you operate as a clinician, you're operating within an employer who is able to sort of guarantee the setting within which you work. And so if you're not working within that setting, there's a question about whether your scope of practice now applies, which can get you into some legal gray area. And so I would say, depending on how one is thinking about independent, worth having some further conversations as you're conceptualizing what that means and what that looks like and how it's structured. It's not that it's not possible, it certainly is. You just want to be very thoughtful about what you can and can't do when you're situated within and outside of different institutions.
Yeah, that's very important to acknowledge. Thank you for that, Nick. We did have lawyers have always been involved in the when, how, and where of our care. And in the medical records, we do have a field that says, where are you, the provider, located? Where is the caregiver located? And that's very important to be documented.
Very, very good. And Dr. Odom, for you, are any services for caregivers provided via a support group process, especially on inpatient units? You're aware of?
I mean, those certainly exist. I would say a support group is probably one of the more common things that folks will find is available for caregivers, albeit many are sort of for patients and caregivers are invited. It's great when folks can have a caregiver specific support groups. I think support groups are great for some, not for others, and that there's certain things you can and can't do in a support group that are better one-on-one. You certainly can't manage medications in a support group. So long as that a support group design aligns with what the objectives are of the support that you want to provide, that's great. And you know, it can exist in all kinds of contexts: inpatient, outpatient, virtual. I mean, there's you know, a whole universe of options there.
Excellent. Dr. Applebaum, another question about, are there any other institutions who have already successfully implemented another caregivers clinic or replicated your model?
I believe there are. I believe UCSF has implemented a similar model of care. And I know that there are many folks I see in the chat who've reached out to me to speak about stepping up and developing similar models. You all are, I'm not going to name you, and you're welcome to self-identify yourselves, but I do know that UCSF has begun doing this type of work. And look, our hope is that when Rachel asks me this question in a year from now, my answer is yes, I know about 45 different programs and they've all established these clinical services in 2024. So really looking forward to re-answering the question.
That's right. And 45 of you guys who have attended are now the champions, right? So it's incredible to see where you're from too, by the way. Thank you so much for including that. People across the country in California who join in the morning and then all across the United States. So it's just incredible. Thank you so much. And then also suggestions on strategies. Both of you guys could answer. This will be our last question. On developing a caregiver program if you really can't identify a champion within your cancer center?
Well, you become that champion. You just have to have a louder voice, right? And I think it's really having a louder voice, the compelling argument, and we've laid out in the toolkit all elements that you should have in making that argument to the cancer center, and maybe even getting a group of individuals. Maybe there's not one champion, but maybe there's a passionate group of colleagues, 3, 4, 5 of you who are going to be that champion. And so I think that too could be very successful based on the voice you have and the way in which you use your voice. So I think look, there are going to be many cases where you can't identify that champion, and we're going to just be creative and flexible, because that's what we do to provide support to caregivers.
Yeah, I mean, champion, you know, nomenclature aside, it's just a term we use for someone who is willing to invest some time, potentially resources, in supporting an initiative to develop a program. You don't have to call them champion. You can just call them, you know, your outpatient service line director. I mean, if they're attending a meeting once a month or a quarter to help you, sure, they're a champion. They might not self-identify that way, but they're willing to show up and hear what it is that's going on. And so whether you call it a task force or a work group, call it what you want. I mean, I think that you do want to try and gather together an alliance of some sort of individuals who are willing to invest time and hopefully resources. I do think that one will have to adjust expectations of what a program can deliver if you do not have support of leadership with some levers, with financial and hard support like space and stuff like that. And even then, it's not like you can't do anything. You certainly can. You can still offer certain services. You just have to be thoughtful about how you structure the objectives of the program and what its purpose is and what its scope is. And there's no wrong answer here. There's a million right answers. In anything, no matter how small or how big, is great. So don't think that you need to develop something that taps into all 9,000 new inpatients that come in each year. It can be, you know, something that just serves a very small proportion under one oncologist. That's a start.
That's right. That's right. Well, thank you again so much, Drs. Odom and Applebaum, for being here today and being with us through the rest of this series. We'll see you guys in 3 weeks for our session number 2. If you haven't already, please go ahead and start reading through our Caregivers Clinic Toolkit. And please download these caregiver resources, distribute them far and wide with all of your networks. And we'll see you back in 3 weeks for the session 2. Take care.
Thank you.